This is a flowchart for duodenal cancer treatment in Japan. For TIS and CTYA lesions, endoscopic resection is generally recommended. Patients with pathologically T1B or lymph vascular invasion are usually referred for surgery. For more than series resectable lesion, pancreaticoduodenectomy (PD) is the standard treatment. If the tumor cannot be removed, chemotherapy is administered. Today I will talk about the treatment of duodenal cancer. I am a gastrointestinal endoscopist specializing in the endoscopic diagnosis and treatment, especially duodenal lesions. Interestingly, uh, the number of duodenal lesions in our hospital has been increasing. We perform endoscopic resection for some duodenal lesions. However, a part of patients are unable to meet the criteria for cure and require additional treatment. This is a flowchart for duodenal cancer treatment in Japan. For TIS and CTYA lesions, endoscopic resection is generally recommended. Patients with pathologically T1B or lymph vascular invasion are usually referred for surgery. For more than series resectable lesion, pancreaticoduodenectomy (PD) is the standard treatment. If the tumor cannot be removed, chemotherapy is administered. When the lesion is adopted to surgery or chemotherapy, we sometimes find ourselves unsure of which one to choose. This is the difference of surgical procedure. Local resection is less invasive and preserves quality of life, whereas PD provides systematic lymph node dissection and potentially better outcomes, however more invasive for patients. Chemotherapy is usually based on FOLFOX-derived regimens, but evidence remains limited because duodenal cancer is a rare disease. There are the issues currently identified. First, first of all, because endoscopic diagnosis of duodenal lesion is extremely difficult, it is necessary to establish a reliable endoscopic diagnostic method. We are now currently investigating a relatively simple endoscopic diagnosis that does not rely on biopsy. Regarding of the surgical procedure, I propose that pancreaticoduodenectomy should be recommended for T1B or deeper lesion because the rate of lymph node metastasis increases with the depth of invasion. In contrast, local resection may be considered only for intramucosal cancer because the risk of lymph node metastasis is extremely low. This meta-analysis showed curative resection and lymph node metastasis are the most important prognostic factors for duodenal cancer patients. Then advanced chemotherapy is recommended for patients who could not undergo curative surgery or who had lymph node metastasis, although the optimal regimen remains uncertain. Consequently, the importance of discriminatory treatment for duodenal cancer will continue to grow. Thank you for your attention.
Thank you. We have a few time for discussions. I will first turn to the room if there are any questions or comments from the room on any cases presented. Well, if not, anyone from the panel, if they would like to make any further comments regarding each other's positions. Please, Dr. Bates.
I would like to ask Trevor a question. So the patient didn't like the idea of an APR and a stoma. Patient got an APR and a stoma and there was no tumor in it.
That's right, yes.
What was the patient's reaction when you told that?
Well, this patient was initially quite reluctant to have a stoma, and at that time, our institution didn't have a policy of watch and wait. This was before I arrived at the institution. And so because of abundance of caution, and that they didn't really know too much about the underlying disease pathology, they decided to offer surgery for the patient. But obviously, the result was PCR in the end. So, in some ways, obviously, that's in hindsight a disappointing result. But then it's very difficult for colleagues who have not had very much experience in the field of watch and wait. So I'm hoping to raise the profile of complete clinical response, and hoping to spread the message that with good tumor underlying biology and a better understanding of the endoscopic response and the radiological response, then we may be able to offer more patients the opportunity for organ preservation.